To Carl and Gunnar and George and everybody for inviting me over to this beautiful city. I have to be mad at George a little bit because he puts me up here with people who are world-class researchers, and he gives me 2 talks to do with the fewest number of clinical articles, and I'm just a poor clinician. So we're going to muddle through this together. Sildenafil has obviously become very popular, and hence, with its increasing popularity, maybe we can try and make some sense out of this. I'm from North Carolina, which is that little red state in the middle of the east coast of the U.S., and on the left side you can see we go from the mountains to the sea. In transportation, we've gone from being the first in airplane flight to NASCAR, and in technology, we've gone from being the tobacco capital of the United States and maybe even the world to now the Research Triangle Park, which is the home of many companies that have offices here in Europe. This is a cartoon by the people and Santayan, who does wonderful work, but I'm going to try and build on what Judy talked about before, which is stating that normally there are high phosphodiesterase 5 concentrations present at birth, followed by a rapid decrease in PDE5 expression and activity, increasing cyclic GMP, which causes pulmonary vasodilation. So all these things that dilate the smooth muscle cell of arteries, we're going to focus over on this side where PDE5 lives and its effect on cyclic GMP, calcium efflux out of the cell, and smooth muscle vasodilation. So in the Lamb model of pulmonary hypertension, there's the activity of vascular soluble GC is diminished, and the activity of phosphodiesterase 5 is abnormally increased. And so therefore, those 2 things together combine to lead to decreased cytosolic GMP concentrations and the lack of pulmonary relaxation. Judy already mentioned this part about high inspired oxygen concentrations, and you saw several slides addressing part of that. This one relates specifically to PDE5 specific activity, and you can see that it is significantly increased with 95% oxygen, and indeed even 50% oxygen. I guess I'm stuck. Has a significant increase over room air. So high inspired oxygen concentrations that we use to treat pulmonary hypertension in babies increase PDE5 activity and therefore may actually inhibit some of the responses to the vasodilators such as sildenafil. How does sildenafil work? Well, it structurally resembles cyclic GMP and acts as a competitive inhibitor by binding to the active site of phosphodiesterase 5. Another cartoon here from Robin Steinhorn, so you can see that phosphodiesterase 5 inhibition promotes vasodilation, and that's precisely where sildenafil acts. Judy also mentioned the different presentations of pulmonary hypertension where you have abnormal constriction of the pulmonary vasculature due to significant lung diseases, Meconium aspiration syndrome, RDS, and pneumonia, and the associated hypercapnia, acidosis, and alveolar hypoxia. Then there's so-called idiopathic PPHN, where there's the abnormal pulmonary vascular remodeling. Sometimes this can be associated with maternal NSAID use, and now there's even case reports of maternal SSRI use being linked with pulmonary hypertension. And then there's babies that have abnormal and diminished pulmonary vascular beds due to pulmonary hypoplasia associated with things like congenital diaphragmatic hernia or renal agenesis. So since the underlying pathophysiology differs, different pulmonary vasodilators may be more or less successful for treatment. And as you saw, Judy's heading down a path with citrulline as being one of those other ways to do this. And it would be nice if we had a more thorough understanding about what was disrupted in each condition. Why is pulmonary hypertension part of meconium aspiration, and which pathway may work and which vasodilator may be more successful in that group. So if you remember that in the NINOS trial, and this is true of the other trials as well, for nitric oxide, 51% of the infants had meconium aspiration syndrome as their underlying cause, so a large number of those babies in the NINOS trial. And as Judy again said, treatment with inhaled nitric oxide decreased death and decreased ECMO, but that was the suggestion that the nitric oxide cGMP pathway might work. But are PDEs, as a part of this, are they specifically dysregulated in meconium aspiration syndrome? And I don't think we know. What about congenital diaphragmatic hernia? Well, inhaled nitric oxide, again, did not decrease the death rate or the need for ECMO. But there was a case report not that long ago that showed successful treatment post-repair of congenital diaphragmatic hernia after a combination of sildenafil and prostaglandin E1 in a baby who failed inhaled nitric oxide therapy and inotropes. So in relation to that, there was people in Glasgow. I don't think anybody, there might be one or two people here from the UK, but they looked at their experience that grew over time. So they looked at 2000 to 2006 with a total of 80 babies who were treated with congenital diaphragmatic hernia. And up on the top there, I'm still just losing it here. Try that one. There we go. So on the top, you can see in 2000 and 2001, none of the babies received sildenafil. They had survival of 45 to 67%, 11 to 18% receiving ECMO. Then they started using sildenafil to treat some of the babies. And they went from a quarter of the babies up to almost half of the babies over a period of 3 or 4 years. But the number of babies receiving ECMO really didn't change, and the survival really didn't change either. So here's another case of one more therapy that does not seem to make a big difference in terms of the outcomes for diaphragmatic hernia. And indeed, there may have even been a downside in that the babies who got sildenafil had a longer time on ventilator support, significantly longer, a longer time on inhaled nitric oxide. They got more echocardiograms. Their mortality, although it was not significantly different, was a trend in the wrong direction. And yet they described no adverse of sildenafil were described. Well, you know, so is longer time on ventilator, longer time on inhaled nitric oxide, and higher mortality adverse effects? Probably. It's not hypotension, and it's not maybe a direct treatment effect of the drug, but you wonder, is there something, again, ill-advised about using sildenafil for babies with diaphragmatic hernia? Their starting doses were pretty typical for what I think everybody is using who uses sildenafil. So you always hope when you're a clinician that you can go to a Cochrane review and they can tell you what to do. Unfortunately, many times that's not the case. So in the most recent update to sildenafil was done last year, and they found 3 trials that were eligible for review by their criteria with only 77 babies in these trials. All of these trials were in, we'll call resource-limited settings, places like Mexico, Colombia, et cetera. Their methodologic quality they called, quote, a low to moderate risk of bias. And what those studies all suggest is that there was improvements and changes in oxygenation index. So after the first dose of sildenafil, you can measure changes in OI. And based on the small amount of data in those trials, no clinically important side effects were identified, and there was a significant reduction in mortality in the sildenafil group. So you can see that here is a relative risk 0.2, so definite drop. And the number needed to treat to benefit was really small. I mean, think of some of the other trials or other therapies where it takes 16 or 20 babies to get needed to treat for benefit, and here you have a number of 3. How many people have used the sildenafil to treat pulmonary hypertension? Maybe half. How many people use it routinely to treat pulmonary hypertension? Nobody. Gracious. All right. So the author's conclusions for the Cochrane review were sildenafil in the treatment has a significant potential, especially in resource-limited settings, as a good treatment. But they're, again, as usual, recommending a large-scale randomized trial comparing sildenafil to inhaled nitric oxide to assess both efficacy and safety. So what were these trials that they reviewed for the Cochrane review? Well, number 1 was the one from Colombia that was published in 2006, 13 babies with a randomized mass trial. And this is in Colombia where there was no availability of ECMO, no high-frequency ventilation, and no inhaled nitric oxide. These were babies who were very sick with severe pulmonary hypertension with an oxygenation index greater than 40, certainly the worst of the worst. All of them had significant lung disease with either meconium aspiration or respiratory distress syndrome. All were on the conventional ventilator. They enrolled them in the first 2 or 3 days of life, and they actually randomized and masked sildenafil versus placebo. They extrapolated a dose from the adult literature, and the adult literature, as you know, is Viagra for erectile dysfunction in males. They then got extrapolated to pulmonary hypertension in adults that then got extrapolated to pulmonary hypertension in babies. But they took the Viagra tablets and crushed them and mixed them in Orabase, and as part of their protocol, you could go from 1 milligram per kilogram per dose to 2 milligrams per kilogram per dose if your OI did not improve and your systemic blood pressure was stable. They limited it to 48 hours of treatment and up to 7 doses. And if your OI got down below 20, then you did not receive any more study drug. 4 of the sildenafil infants got all 7 doses. 2 got 6 doses. There was 1 death. 4 placebo infants got all 7 doses, and there were 2 deaths in that group. Their version of the Data Safety Monitoring Committee stopped their study because the predetermined criteria of when they reached 6 deaths during the study, they would stop the study. When they stopped it, what they found was that the deaths were primarily in the placebo group. So there was only 17% survival in the placebo group, 1 out of 6 babies. 2 of the babies died before 48 hours of age. The other 3 died by day of life 10. On the other side, there were 85% survival, or 6 out of the 7 sildenafil babies survived. And when they compared the pre- and post-study survival to the sildenafil group, again, it's significant. So pre- and post-study was 20 to 35% versus the 85% in their sildenafil group. They quote, no noticeable effect on systemic blood pressure, but they did not report those numbers, and there was no evidence of rebound hypoxemia. The biggest change they saw besides survival was the improvement in the oxygenation index, which again seems to be everybody's at least anecdotal experience, and you can see that the black bars, significant improvement 6, 12, 24, and 36 hours, whereas the control group, the oxygenation index really did not improve at all. To their credit, they went ahead and did developmental follow-up at 18 months of age. Only 4 of the 6 survivors, however, were assessed, but of those 4, they all had normal neurologic exams at 18 months of age. They all had normal developmental quotients. They had normal MRIs. They had normal EEGs and evoked potentials, and they had growth parameters, including head circumference, that were all within normal limits. This is the only study that I know of that's done developmental follow-up in babies that have received sildenafil. And as you can see, there's 4. On to Mexico. This one was published a couple of years ago. Again, a resource-limited place with no high frequency and no ECMO. They did 51 babies who were term and under 48 hours of age. The criteria were less strict in that their oxygenation index was only greater than 20, as opposed to the Columbia study when it was 40. Partway through this study, near the end, inhaled nitric oxide actually became available, and it was given to the last 5 babies in the placebo group. They gave a higher dose of sildenafil. Didn't really explain very well why, except they thought that more might be better. And so they gave 3 milligrams per kilogram every 6 hours, and they used a crushed tablet and water instead of the Orabase, and they stopped treatment when the oxygenation index was less than 10. Again, a typical distribution of PPHN babies, lots of meconium aspiration and pneumonia, sepsis, asphyxia, and you can see that their oxygenation indexes were scattered from 20 to greater than 40, with roughly half the babies having OIs greater than 40. So even though their entry criteria was an OI greater than 20, a significant number were having severe PPHN. Looking at the oxygenation index, which again is the easiest thing to measure, you can see that in the placebo group it really changed very little. The sildenafil group had a significant decline in the first 24 hours after the dosing began. Comparing survival again, there was 93% survival in the sildenafil group and 60% survival in the placebo group. When you tease out those statistics even more, one of the 2 deaths in the sildenafil group had an OI greater than 40, whereas 7 of the 8 deaths in the placebo group had an OI greater than 40. So the mortality was really only significant in patients that had the most severe disease. So the babies who were less severe disease had the same mortality rate. Those with an OI greater than 40, much better survival in the sildenafil group. And remember that towards the end of the study, inhaled nitric oxide became available. They gave that to 5 babies in the placebo group, and nobody died. So again, sildenafil seems to work in severe pulmonary hypertension in places that don't have inhaled nitric oxide or some other therapies. From the limitations of the papers, none of the patients showed hypotension. You can see the number of doses that were given, and remember that they treated until the OI got less than 10, as compared to the Columbia study where the OI was less than 20. Well, one of the concerns about sildenafil is that you're giving it orally, and there obviously are very, very, very few drugs, if any, that you give to sick neonates in the first few days of life that you give orally. Most things we give IV for many reasons. And so this study was the Dutch study. Where's my Dutchman? There he is. Looking at serum concentrations measured after several days from ECMO. So these babies were all on ECMO and all got decannulated, and then there was a pharmacokinetic study done. And you can see that these serum concentrations after oral dosing, and the dosing range from 0.5 to 3 milligrams per kilogram, start from almost 0 up to a very high level of 700 nanograms per ml, and then there's a decline over time. But a significant number of babies here, maybe half, this is 11 patients total, so roughly half the babies have almost no measurable level at all. So is that oral absorption, or is that some other? And they said they were, quote, unable to explain the variability based on things like gestational age or degree of respiratory instability, et cetera, or blood pressure. So what about oral dosing? Well, if you look at adults, it's rapid oral absorption. You have a peak concentration reached in 30 to 120 minutes and approximately 40% bioavailability. We don't know what the oral bioavailability is in babies. The closest we have is this study here suggesting that some proportion of the babies may not absorb very much drug at all. And so when you're looking at clinical response, is it because it's the disease process that doesn't respond to the drug, or is it just the fact that you don't get the drug in there at all? How is sildenafil metabolized? Well, in adults, it's N-demethylation by the cytochrome P450 system, primarily 3A4, with some contribution of 2C9. We don't know what it is in neonates. The primary metabolite has approximately half the phosphodiesterase 5 inhibitory activity of sildenafil. So not only do you have parent compound with inhibitory activity, you also have the active metabolite. And again, how does that play out in neonates? And I don't think we really know. If you go back to a paper that was published by Greg Kearns reviewing the changes in pharmacokinetic parameters in babies over time, you can see that 3A4, which is the enzyme we were interested in, changes somewhat in the first few days of life, and then marked changes after roughly a month of age. So in these first few days of life when we're treating babies with persistent pulmonary hypertension, there may be some maturation of 3A4, but to what degree we're not exactly sure. Remember that if you are using sildenafil, that other drugs that are 3A4 inhibitors, such as fluconazole, erythromycin, amlodipine, or cimetidine, will increase sildenafil concentrations by interfering with its metabolism. Recently, an intravenous form of sildenafil has become available, at least in the US and some other countries. It's called Revatio. And there have been, it's put out by Pfizer, and there are studies looking at the intravenous dosing now instead of just oral dosing. Now, as you might imagine, oral Viagra is cheap. It's generic, and you can get it for literally pennies a pill. IV sildenafil is at least $20 a dose. Be that as it may, there was a multi-center trial done in the US, the UK, and France with typical PPHN babies, so those that were less than 72 hours of age, near term or term. The oxygenation index was greater than 15, and there was 36 babies in this group, with 29 of those 36 receiving inhaled nitric oxide. By far the majority of these babies had significant lung disease, with only 2 of the 36 having, quote, idiopathic PPHN. They were the usual sick babies with mechanical ventilation, pressors, and sedatives. They excluded them, to their credit, with significant renal or hepatic dysfunction, and they also excluded babies with congenital diaphragmatic hernias or those with structural congenital heart disease. So this was a dose escalation trial. So it was unclear, obviously, what the best dose, especially intravenously, was going to be for babies. So they started very low, 0.008 milligrams per kilogram, and escalated up over time to 0.4 milligrams per kilogram. So you can see that's a huge dose escalation. And the loading doses, the infusion time started out at 2 minutes, but because of systemic hypotension, they gradually increased the loading dose time, and then by the end of the trial, it was up to 3 hours. The maintenance doses range from 0.01 to 0.22, and you can see that the dose escalation was based on the PK data and tolerance from the previous group. So they would do 2, 3, 4 babies, look at their data, adjust the dosing, do 2 or 3 or 4 more babies, look at their data, adjust the dosing. Based on some adult data, they targeted plasma concentrations of 40 to 350 nanograms per ml, but because of the small size of each cohort, again, 2, 3, 4, up to 6 babies in each treatment group, they could not really determine the therapeutic level. The smallest loading dose to reach the minimum threshold of 40 nanograms per ml was 0.12 milligrams per kilogram delivered over 30 minutes. But when you go back and you look at these levels over here, which some of you may not be able to read, but these are the levels after the loading dose here in the middle of the screen. Over here are the levels after a period of time on the maintenance dose, and even at the lowest doses underneath the line here, all babies had some form of drug accumulation, meaning that their steady state level, they never actually reached steady state. They had a level that was higher during the maintenance phase than it was after the loading dose. What else have we learned about sildenafil? Well, the volume of distribution is large relative to adults when you correct for weight. It's 2 to 3 times larger on a per weight basis than it would be in an adult. Protein binding is lower than adults, but very close. And based on this pharmacokinetic study here, and this group here, this Mukherjee, and published in Clinical Pharmacology and Therapeutics, this group of authors is all the people who work for Pfizer. And they were the ones that were doing the study with Robin Steinhorn's group. And so even though you're reading 2 separate papers and they're presented in 2 different ways, it's actually the same study in the same babies. But what they found was very slow clearance in the first few days of life, but a rapid increase, a 3-fold increase in clearance during that period of time. What happens with the IV loading doses in clinical response? In these low doses, less than 0.03 milligrams per kilogram, they had very little change. That's the black line. When they gave a larger loading dose, within 4 hours, they saw a significant change in the oxygenation index. So again, both with oral dosing in the babies who respond and with intravenous dosing, if you're going to see a response, you're going to see it in a relatively short period of time. Remember that there were 6 babies in this trial who did not receive nitric oxide. They all responded to sildenafil based on improvements in their oxygenation index over the 72-hour period. 1 baby in this group died. Adverse effects. Hypotension, because it's a vasodilator, and even though it's a relatively selective vasodilator, some babies are going to have systemic hypotension. And in this trial, it was 2 of the 36 babies. And these were babies that were treated early on who got the loading doses in the shortest period of time, over minutes, as opposed to over an hour to 3 hours. So the slower loading doses, even those that were on the higher end, as long as they were administered over a long period of time, in this case 3 hours, they did not cause hypotension, but that's only 4 babies. Is there any other way to give sildenafil? Well, sildenafil, if you want it to be a selective pulmonary vasodilator, maybe you can give it intratrachely. And so in a piglet model here of meconium aspiration, they gave a single dose intratrachely, and indeed they had a rapid response. The white bars here, a drop in a drop somewhat in systemic blood pressure, as well as pulmonary blood pressure. So even though it was given intratracheally, at least in this piglet model, and you did have pulmonary vasodilation, you also had a drop in systemic blood pressure as well. Can we give it via aerosol? Again, another intriguing idea, because perhaps you're preferentially delivering it to the better ventilated areas of the lung and not to those where the VQ mismatch is. And again, because it's a pulmonary vasodilator, but I haven't seen this study repeated, and it was done in a lamb model in 2001. What about using it to wean nitric oxide? This study was in children who were receiving nitric oxide for pulmonary hypertension, 5 parts per million. And while they were on nitric oxide, they were randomized to receive either sildenafil or placebo, and a single oral dose was used, 0.4 milligrams per kilogram. So a lower dose, but again, these are older infants and children, and only a single dose, but this single dose in their study with 15 babies prevented rebound pulmonary hypertension, suggesting that there may be a role for sildenafil as not a primary treatment, but an adjunctive treatment in babies who either aren't responding to nitric oxide or have trouble getting off nitric oxide. Does ECMO change the pharmacokinetics? I mentioned before the study that was done in the babies after they were decannulated, and you saw how variable the oral absorption was. But the other part of that group studied looked at how the volume of distribution changes, and so when you're on ECMO, you have to give a higher dose, perhaps as much as 5 to 7 milligrams per kilogram per day. When you get decannulated and you come off the ECMO circuit, you could drop down to 3 to 5 milligrams per kilogram per day. Sildenafil and hypothermia, since we've been talking about hypothermia, I don't know of any data. What about its use in premature babies? Well, sildenafil causes transient impairment of color discrimination in adults. It's one of the well-known, well-documented adverse effects in men taking Viagra, for example. And so the concern, obviously, is that there's the potential to increase the risk of severe retinopathy of prematurity if you use it in the premature babies who may display signs of pulmonary hypertension. This was just published in the last 2 months. This is a case control study, and this group concluded that, quote, sildenafil treatment did not affect ROP progression or increase the need for laser treatment in this cohort. So they actually said that it's, from their standpoint, it would be okay to use sildenafil in premature babies. However, if you go back and you look at this study more closely, you'll find that one, even though they had 3 controls to every case, the controls are really poorly matched. The amount of time on the ventilator was much longer in the sildenafil group. The use of postnatal steroids was very high in the sildenafil group. What do you make with that? I don't know. The overall incidence of retinopathy, all forms of retinopathy, was actually slightly lower, again, but not statistically significant. And yet stage 3 retinopathy was seen in 24% of the sildenafil infants versus only 12% of the control infants. So do they have the data to say that it does not affect ROP progression or the increased need for laser treatment? Not so sure. So I don't think that it's ready for prime time in premature babies. So my conclusions at this point are that, one, you would limit treatment to patients who are, one, refractory to inhaled nitric oxide therapy, or those who are persistently unable to wean off of nitric oxide, and in situations where nitric oxide is not available. Even in the US, where we have pretty easy availability of inhaled nitric oxide, I had a case one time of a baby who was in a rural hospital that was several hours away, had saturations in the 60s. Our transport team could not make them any better, and this was prior to the availability of nitric oxide on transport. Even this small rural hospital pharmacy had Viagra tablets in their pharmacy, and we gave them 1 dose. Saturations came up to 90%. We brought the baby to our hospital and then put them on nitric oxide. There's also one case report of improved pulmonary blood flow in babies who have severe Epstein's anomaly. Certainly you would monitor for worsening signs of oxygenation or hypotension, And that would be the reason to be cautious in babies with sepsis who have other forms of vasodilation already going on. And I think really at this point in time, use in extreme premature babies should be considered experimental. What about the dose? Do we know the correct dose? Well, it depends on who you ask, so no. In NeoFACS, I wrote 0.5 to 2 milligrams per kilogram per dose every 6 to 12 hours, primarily based on the study from Columbia. The neonatal formulary in the UK says start at 0.3 milligrams or 300 micrograms per kilogram every 6 hours. An increase is required to no more than 2 milligrams every 4 hours, which would actually be a lot. And then the British National Formulary for Children actually has a different dose than the neonatal one and talks about administering every 6 to 8 hours. So there's a range of doses that have been recommended in standard reference sources, and now you know without a lot of data. The IV loading dose based on the paper from Steinhorn would be somewhere in the neighborhood of 0.2 to 0.4 milligrams per kilogram, and the important point, if you're going to give it IV, is to give it very slowly with a loading dose and then a maintenance infusion that's pretty low. This Revatio is the drug manufactured now that comes in a single-use vial, and a paper just published shows that you can actually dilute it in D5 and it's stable for 7 days, so you at least can diminish the cost by having a compounded dilution. So start at the lower end of the dosing range, titrate based on response, and if you're using the IV form, administer the loading dose over at least 2 hours. I'm going to point you to 2 reviews. This one from Kathy Farrell and Robin Steinhorn about emerging therapeutic targets, which I think plays into some of the things that Judy's already talked about. And then this from Nicoletta and the group in Greece. The use of sildenafil is a nice review because it talks about some of the animal studies and the basis for other treatments of pulmonary hypertension. I apologize ahead of time for not having these posted on the IPOKRaTES website, but they will be on tonight and you'll be able to download it after that. Thank you.